So that for sure, I'm gonna say it again just because Adam just started recording. So for sure, know the blood alcohol like toxicity is 100 to 200. That for sure was on ours. And then, or like that's when intoxication starts between 100 and 200. And then that your biggest worry with someone who's going through withdrawals is actually going to be safety because they will experience so many symptoms that could be dangerous. And so like your biggest concern isn't going to be um, like that they're angry or like it's not going to be personality, it's going to be more like physical safety. Like they're going to have such extreme, so people that are like highly addicted to alcohol will have such extreme experiences or body symptoms that were so like some of the symptoms is like nausea, vomiting, lethargy. Oh wait, these are just long term, hold on. Okay, well, I'll find it, but there's like some really serious ones so that like if you get a question and I have one in here, like your biggest concern is going to be it's not going to be like imbalanced nutrition or ineffective coping or anything like that. It's going to be like risk for safety. Just because it is such a huge like detox process for them. Those for like that first few days, like especially within the first few hours. I'll find it, but I think she has a slide that talks all about like the side effects, like signs and symptoms, sorry, that you're gonna see. Okay, so let me start actually let me put the sign in the chat.
Thank you for your help, Lauren, on that.
For my what?
For my help on that.
Oh yeah, the email that I sent you. What are you talking about? Okay. what are we talking about right now? Yeah, no problem. Yeah, if anyone for B80, if you're like, I'm not really sure, if you like certain dates you don't remember. I mean, I can't do this for everyone because that would take a while, but if there's like certain dates that you're like, was I there this date? Like, let me know because I have to turn in all of these forms online. And so I have access to all of them. And so I can see like if there were certain days that you were there or not. So, okay. Let me share to the Kahoot. And then one thing to remember with the Kahoots that I make that I don't think I was ever very clear on is that unfortunately Kahoot has like a 120 character limit on questions, like no matter what premium level you buy, which is really stupid. So sometimes I like my sentences are very like shortened with like abbreviated stuff. Like I wish I could do really great like scenario questions for you guys that you'll see on the test, but I only have 120 characters. So I do the best I can to kind of make it like similar, but there will be like, especially on this one with Psych, when a lot of it's more like scenarios, there's going to be a lot of um, like abbreviations and stuff. And then with OCD, remember that OCD, I think she probably talked about this with you guys, that OCD, like what we think about is different than like obsessive compulsive personality disorder. So when we think OCD, we think somebody that has to have their house nice and neat, or they have to wash their hands 5 times before they open the door or whatever. And that's different than obsessive compulsive personality disorder. So personality disorder is more like they're like very inflexible. They can't handle at all any sort of like schedule changes or they're not able to like have any sort of like spontaneity, things like that. But in the Kahoot, because obsessive compulsive personality disorder is so long to write out and it took up all of my character spaces, I wrote OCD a lot. So just make sure that like you recognize the difference because in here I shortened it to OCD, but that is a different disorder than obsessive compulsive personality disorder. Guys, can you stop that Alexa timer?
Where Alexa stop?
It's in the kitchen. Whose timer was that? Okay. Okay, guys, 5 seconds, then we'll start. Nathan. Or tell Max he needs to shower and get ready for bed. Sorry, my husband's at like a meeting tonight, so I'm in charge of bedtime. Okay, I'm gonna go ahead and get started. A patient has pushed the PCA pump button 100 times in 30 minutes. What is the best rationale for assessing for substance addiction? So why would we assume that the patient has a substance addiction, and why would we want to assess that? Okay, so yeah, it's that they're addicted, patients that are addicted to alcohol or benzodiazepines, they can develop cross tolerance to analgesics, so they may need a higher dose. So something that I feel like the psych exams, like especially the ATI, and then from what I've heard with NCLEX, will try to get you on is confusing our role that we're nurses and not police officers. And so it's not really our job to punish the patient if we feel like that they have like an addiction, or to like try to catch them in their addiction or like anything like that. Like really our job is like to treat them like any other patient, and then to take care of them, like their physical and emotional needs. So like, yes, sometimes we do have to refer like police, like get police involved, like if we see drugs or anything like that. But we're mostly concerned that patients will develop this cross tolerance. And so a normal dose of analgesics like morphine for someone that's addicted to alcohol or benzodiazepines won't, like that won't work for them. And so maybe like for me, who doesn't have that addiction, like that would be fine. But for someone who does have that addiction, that's not high enough for them. And so we need to kind of assess, like, do they have any sort of addiction? Because if they're sitting there pushing that pump 100 times in 30 minutes, it's not working. And what we're most concerned about is we want to be able to help their pain. And so we want to assess if they have an issue. And then if they do, talk to the provider to get a higher dose ordered for them in that PCA pump. So that way it actually meets their needs and they're not sitting there in pain. So there's nothing that's saying that they are going through withdrawal symptoms. Narcotic pain medication is not contraindicated. So we can give narcotic pain medication. And I know that seems a little counterintuitive because sometimes we're worried about drug-seeking patients, but in this situation where they have a PCA pump, we can assume that they went through surgery or something happened that they're being put on a PCA pump, because we're not just giving those out to anybody that walks in complaining of like back pain or something, right? So those are usually reserved for patients that have legit physical issues. So we're okay to give them narcotic pain medications. And they don't have a high pain tolerance, like higher than normal. Their pain tolerance is the same. They just will have this cross tolerance.
Why is it? They don't have why not?
A patient diagnosed with paranoid personality disorder becomes violent. Which intervention is most appropriate? And this could work for any personality disorder. It doesn't have to just be paranoid.
So no, YouTube won't let you watch videos unless you turn on ad blockers. Like you literally can't watch it.
Okay, awesome. So we're going to use clear, calm statements and confident physical stance. So I always think about in the psych unit, we are kind of treating the situation the same as we would kind of like with a group of children. And I'm not saying that in a demeaning way, but just that like when you're a teacher in a classroom full of children, we're always being clear, calm, we have confident physical stance, and we have clear set rules, because otherwise a lot of these personalities disorders that they have, it kind of makes them react in childish ways, right? So with bipolar disorder, they can have this like, high manic and then, super down depressive. And then with BPD, they can, really try to manipulate you, and they're very like dependent and like clingy. And so they kind of have these really childish, like, I don't know like the right word, but they're kind of acting out in ways that the same way that children would react. And so what is best for them is to actually just use these very clear, concise, like, these are the rules and you need to follow the rules. And they actually accept that fairly well once they're medicated. So we're always going to have this like a confident physical stance to show like we're serious, but we're going to use like very clear, calm statements. And then it's also best to have like staff with you to show like a force of like we're all together, especially with bipolar disorder patients. Borderline personality disorder patients, because they will try splitting, right? You guys remember what splitting is?
Yes.
Okay, what is it?
Where they try to play people off of one each other.
Yeah, awesome. So they're gonna go up to one nurse and be like, you're my favorite nurse and you can't leave because this nurse is mean to me. And when you're gone, they like, take things from me and whatever. So they're going to try to split the staff and get staff like going like head to head against each other. Another really good question I saw that I wasn't able to put in here just because of space, but I feel like it was a similar one on the test, was it said something like, I always say bipolar, a borderline personality disorder patient during like group therapy, or maybe it was just like in the unit, they start complaining that the unit rules aren't fair, and they get a lot of the other patients on their side. So they're kind of almost creating like this like riot type of feeling, right? Like very very disorganized, very like, okay, things could go crazy any second. Like, what is the best way to handle this? And like one option, which sounds like a good option, is like, okay, well, like sit down with everybody and use like diplomatic ways to go over the unit rules. And like in a normal circumstance, like maybe in the workplace, that would make sense because you're dealing with rational people. But in a psych unit, absolutely not, because we're not changing unit rules because they're in place for people's safety and it's not up for discussion. And so the way that you're handling that is you're having a show of force, and I say that in like a nice way, like not like violent force, but you have all the staff come together, and so to show we're all on the same side, and we're like, these are the rules, and we can sit down and discuss the rules and the reasons for them so you understand, but these are the rules and we're not changing them, and show that you're all together. Because if you just have one nurse like doing it and the other nurses aren't there, then that's how those patients will start using splitting interventions and try to or splitting methods and try to get the nurses to go against each other. And so you have to realize that they're very manipulative, and just like show that you're a team together with the nurses. A patient with a slightly bleeding paper cut begins screaming, "Call 911, I'm bleeding to death." So what personality disorder would we think that they would have?
Like histrionic?
Well, yes.
Oh, sorry, I didn't realize we're playing. Is this a Kahoot? I'm sorry.
Yeah, it's okay.
I'm so
It's
sorry.
okay.
I'm like halfway paying attention. I'm doing my Jerry day. I'm so sorry, you guys.
No, it's totally
Shit.
fine. It's not a big deal.
Okay.
It's not like it's a real test. It's fine.
Yeah.
It's fine. Don't worry about it. It's totally something I would do. You guys got it all right. So yeah, it's histrionic. So I think there's only like one question on your test about histrionic, or maybe two. But these people with histrionic personality disorders, they like just really exaggerate everything. And they're very they're looking for attention. And so a slight bleeding paper cut, they'll be like, "I'm bleeding to death," or like if they have an argument with their like significant other, they'll be like, "Oh, my boyfriend is like so toxic and he's so abusive." Like they're just trying to get people to like get attention and sympathize with them. And so that's histrionic. And I just always think about it that sometimes you'll see in literature, they'll talk about like, especially with women in the 1800 literature, they'll talk about like how she broke down into histrionics or whatever like that. And so it's just this excessive show of emotion. Antisocial personality disorder, usually they're not drawing super attention to themselves like that. And remember with them that they're not asocial. So they're very social people, and they just, like, you know, she talked about like Ted Bundy and people like that, where they're able to just really convince people that they're their friend, but they feel no remorse for terrible things that they've done. And they don't feel any sort of empathy with people. And so they just really, I mean, it's kind of like when you watch a lot of those like CSI type crime shows, or what's that big one that was super popular? I can't think of it, but like the one where they're like the FBI and they're in like the unit that like, do you guys know what I'm talking about, that show?
Bones?
No, it's not Bones. I'm probably too old for you guys to remember the show.
Criminal Minds?
What was it?
Criminal Minds?
Yes, Criminal Minds. Okay, that is
Good
such a
show.
good show. I love it.
New season back on Paramount Plus.
No way. Oh, I'm gonna have to watch it. I love that show. But I feel like most of their patients always have some sort of bizarre, like they make it act like 90% of criminals are like have some crazy mental issue. And a lot of their patients have like, or not patients, their criminals are like these psychotic people that it's like, oh, they feel no remorse. They feel, you know, like no, like they're just gonna keep killing until we stop them or whatever, because they just don't feel bad. And that's kind of an antisocial personality disorder person. And then it wouldn't be OCD. And borderline personality disorder, they're not so much like, they are looking for like attention seeking, but it's not going to be like a slightly bleeding paper cut and then they turn it into something huge. They will do something impulsive, like they'll take a knife and stab themselves to get the attention. So they're actually going to go to like extreme lengths to do it. Where like a person with histrionic disorder, they're not going to intentionally hurt themselves. They're just going to take something very small and blow it up like out of proportion. Borderline personality disorder is that you have to really watch them, because they will just be so impulsive and do something so unsafe to get the attention. Which symptoms would lead a nurse to suspect that a patient has obsessive compulsive personality disorder? Okay, so with obsessive compulsive personality disorder, they're inflexible and lack spontaneity. So this one right here, they experience the unwanted repetitive behavior. Remember, that's just like OCD without the personality. So it's not something that usually they're going to be in the psych unit for, because they might have like some sort of like cognitive therapy or something. But they're able to usually live some sort of like regular life, where like this person, they're not really able to have a job because they're just so inflexible that they can't handle any sort of change of anything in like scheduling or a lifestyle or anything like that. So they make it very difficult to have any sort of a relationship with or to work with. And experience the unwanted, intrusive, and persistent thoughts. This would be more like probably like schizophrenia. And this is just one that that the test bank had as an answer. And I think it's like one, I think this is one of those questions that like, this could be a right answer, but this is the best answer. So I think with obsessive compulsive personality disorder, it's less obsessive thoughts and more like an obsessive personality. Whereas with OCD, it's more like the obsessive thoughts. Like they think about like, I have to wash my hands 5 times before I do this. So it's more like that obsessive thought that keeps bugging them. Whereas this is like a whole personality that like, that they can't, they're not just thinking something. It's actually like they can't live by an inflexible schedule or routine. it's a little tricky, but there's not going to be a lot on your test about this. And the only thing, she's only going to test you on the personality. So she's not going to test you on like the difference between obsessive compulsive personality and like OCD. So I would just focus on what the definition is of this one. And then you should be able to answer any question just fine, because like I said, it's mostly going to be that borderline personality disorder. There'll be a couple on narcissistic, a couple on antisocial, probably just like one on this, on the obsessive compulsive personality. And it'll probably be very similar to this, just like the actual definition. A patient diagnosed with antisocial personality disorder spits, curses, and screams at the nurse. What is the appropriate response?
Oh, you're kidding.
Come on, guys. Okay, so I feel like on our test, there was maybe 2 to 3 questions really similar to this. So your best answer, you're always looking for the answer. Like I think it's the teacher answer, right? So think of like a 3rd grade teacher in a classroom where they are firm, but not mean and not like condescending, but they're just like very firm. So they're using that teacher voice. Like, I understand that you're angry, but this behavior will not be tolerated, right? So I just always look for like, okay, what's the one that looks like a 3rd grade teacher, or like that's going to be like your firm, clear, concise response. A bipolar patient attempted suicide. Family reports that the patient is anorexic with recent job loss. What is the priority nursing diagnosis? Okay, good. So it's always going to be safety. Okay. So no matter what disorder it is, your top risk is going to be safety. If they're like, what is the priority nursing diagnosis? It's always safety. She might have something where you have to put them in order. And so for this one, I would do this as first because it's safety and you're going by Maslow's hierarchy, right? So then this would be second, because after safety is taken care of, now you're going to physical needs. So now we're talking about imbalanced nutrition, or like a place to live, like a safe place to live, things like that. Like, do they have good drinking water? And then you're going to like emotional needs, which these would be the same. So I wouldn't know how to differentiate between these two, and she won't make you do that. But then it would be like dysfunctional grieving or severe anxiety, like something like that, right? So you're going with, first is going to be safety. So risk for suicide, risk for self-harm, anything like that. That's number one. Then it's going to be any sort of physical needs, imbalanced nutrition, electrolyte imbalance, like something like that, right? And then higher up is going to be like your emotional needs. And then the very top, she won't go all through all 5. I think it'll just be those 3. It'll be like safety, physical, and then emotional. Because I think the top is like being your best self or something like that. Like something, I don't remember what it's called.
Today in B80, she had mentioned to just know that it's safety, nutritional, sleep, and social in that order.
Perfect. Thanks, Erica.
Yeah.
So yeah, so safety and then nutrition, right? Because that's physical, and then sleep. And then you said emotional?
Social.
Social. Okay, good. Which kind of goes with emotional. So yeah, so sleep is very important also. And so, but that's going to go in between. Like that you're going to have nutrition and safety first, and then you're worried about their sleep.
One second.
A patient is pacing, stating, I could buy and sell this place, while fluctuating between laughter and anger outbursts. So if we're like making nursing notes, how would we describe this? Okay, so they're agitated. So we can tell they're agitated by the pacing. Normally, if a person is pacing, there's some sort of agitation going on. Exhibiting grandiosity. So that is, I could buy and sell this place. So having these grandiose thoughts, like they're better than other people. Like, I have so much money, I could buy and sell this place, or like I'm related to the governor of California, and like just having these like big ideas that there's something bigger than what they are and better than everybody else. When you fluctuate between laughter and anger outbursts, that's a labile mood. I don't know if it's labile or labile. You guys know?
I think it's wild.
Labile. Yeah, L-A, like L-A-Y-B-I-L-E, like
Yeah.
labile. Okay. So I just think of it like teenagers, right? Or pregnant women. They just like fluctuate so fast. So like one minute they're happy and like, best in the world, and then next they're just like sobbing, or they're just like furious or whatever. So that's lability or labile moods. And so especially with bipolar patients, they will show this type of like moods fluctuations. And so it's not this one, it's not really showing they're hyperactive, because they're not like, showing like this manic jumping around. Delusions of reference would be like, I'm related to like the Queen of England or something. And then, but they do have labile moods. So that one just had the one right one. And then this one, restless possibly, but this is not magical thinking. And euthymic mood is actually like a stable mood. So people that have bipolar won't have euthymic mood. So euthymic mood is somebody that's like calm, collected. And so generally what a healthy person shows, like an emotionally healthy person. And so that's actually where we're trying to get bipolar patients, is to like euthymic moods, like with their medication, because they fluctuate so much from like this like really high to really low, that there's not really this middle ground where they're just very stable. And so we're trying to get them to euthymic. And then they're not euphoric, because euphoric means like overly happy. And obviously that's not what we're seeing right here. What is the primary goal of the recovery model when treating patients with bipolar disorder? Okay, so it's patient empowerment. So in the bipolar disorder slides, and I don't know what slide number it is because she doesn't number her slides, but it talks about, it says treatment modalities for bipolar disorder, and it talks about the recovery model. And the whole, like really the primary thing we're trying to get patients with bipolar, and I would say probably most psych patients, is just this empowerment to be able to control, like feel that they can take control of their disorder and use the steps we've given them to live a fulfilling life. And so it says that the goal is learning how to live a safe, dignified, full, and self-determined life in the face of the enduring disability, which may at times be associated with serious mental illness. So that's empowering them, right? So they will never have total absence of symptoms, no matter how great their medications are. Medication compliance is important. That's not that it's not important, but that's not the primary goal. Because if they feel empowered, then they're going to be medication compliance, because they're going to understand, like, in order to take care of myself, I need to be on medication. And then this goes along with that too. So in order to have improved psychosocial relationships, they have to feel empowered enough to want to lead a fulfilling life. So we're really trying to empower them, because having a severe mental like disability or disorder like this is so disempowering. And so they feel like they have no control over their life. And that's why a lot of times they have these self-destructive behaviors, and then they don't take their medications. And there's just kind of this whole like vicious cycle of terrible things. And so we're trying to get them to just really feel empowered that like, yes, I have this hard thing, but I can still live a fulfilling life. I can still accomplish a lot of things. I can still live a dignified life as long as I follow like steps 1, 2, 3. So I would make sure to know, I feel like that was a question on ours about the recovery model, and just that recovery is a continuous process. So it's not like, here's some meds, now you're fixed. And the whole point is to empower them, have them live a safe, dignified, full, self-determined life. So again, I wish she had numbers, but she doesn't. So I'm not really sure what slide this is. Maybe slide 25 is what my iPad's telling me. So right around there, it's a recovery model. Which statements represent positive outcomes for patients diagnosed with narcissistic personality disorder? This is select all that apply. Okay, so with narcissistic patients, what is their big like red flags? Like what's their issue?
They put themselves above others. They think they're better than everybody.
Yeah, perfect. I feel like, especially like with like Instagram and TikTok and whatever today, like you see so many people being like, oh, I dated this narcissist. And it's kind of funny because I think they just like, it's kind of become like a word for just anyone who's kind of selfish, which is all of us. We could all be narcissists at some point. But like the actual disorder is they just have a severe exaggerated sense of self-worth. So on her slide number 11, under personality disorder, she says that they're often grandiose and believe they have an inalienable right to receive special consideration. So I don't know who was talking just now, but she was saying like they just think they're better than everybody else and they have special rights. So like they believe that like if they're the patient in your hospital, then they deserve your one-on-one attention. No other patient is more important than them. They get the best of the best just because they're them. So this right here, we don't need them to list 4 personal strengths because they could list like 25 million probably easily because they think they're good at everything. So that's not really something we're looking for them to do because that's just going to further like increase their ego basically. So we want them to empathize with another patient because a lot of times they have a hard time doing that because they just think they're so much better than anybody else. They can't really empathize with people. We don't care about them listing 2 lifetime achievements because they already, again, have an issue with that. Like that's not a problem that they have. So that's why these 2 are wrong because they already can do that so easily. And then same with this. So already they think they're the best person ever. So we don't want to increase that because this is something they can already do. So we're looking for them to focus on other people instead of themselves. So the narcissistic, they're so focused inwards on themselves. We're trying to get them to focus outward on other people. So we want them to empathize with other patients. We want them to identify a personal limitation. So, okay, here's all these things you're good at. What are you not good at? Like, and normally they'll be like, oh, nothing. I'm so good at everything. Like you want them to be able to really be able to tell us something that they're not good at. And then acknowledge one strength that another patient has by day 2. So like, what is something that someone else here is good at? Because they have a hard time doing that because they think they're the best at everything. A patient has been diagnosed with MDD, which is, sorry. After treatment with fluoxetine, the patient exhibits rapid speed and flight of ideas. MDD is major depressive disorder. Okay, so why are we thinking that the provider needs to discontinue the medication and rethink the diagnosis?
Because
Because-
it triggered their manic state.
Yeah, they're probably
Yeah,
bipolar, not
go ahead.
depressed.
Exactly. So at first they might just be super depressed and like that's what they're exhibiting. And so they go to their doctor and just they're so depressed, they have these suicidal thoughts, they can't get out of bed. And so the provider diagnoses them with major depressive disorder. Because remember, there's no like urine test or blood test that we can be like, this is what you have. So it's just based on symptoms. And so if they're only exhibiting one set of symptoms, there's no way for us to know they're bipolar until that other side comes out. And so they're diagnosed with major depressive disorder, but now after getting treatment with fluoxetine, which is like an antidepressant, now they're exhibiting this manic. And so normally patients with major depressive disorder or any sort of depression, if they're getting antidepressants, anxiolytics, they'll start having a more like kind of regular mood, but they're not suddenly going to be like happy and like manic. Okay, it's not going to turn them opposite. It's just going to kind of bring them back to a more centered like mood. And so if the patient suddenly starts exhibiting manic behavior, then we need to rethink and be like, okay, actually, maybe this patient is bipolar type 1, right? I get them confused. Type 1 is when they have like the manic and the depression, right?
Type 1 is mostly manic with some depression,
It's
yes.
some depression. and Type 2 is
This would be
hypo.
type 2
Okay.
because of major depression.
Okay. But type 2 is just hypomanic, right?
But major depression specifically.
Okay. Okay. So make sure you know the difference between those two. I wasn't very good at like reviewing those before this, so I'm sorry about that. But make sure you know, because there will probably be a question that like gives you an example and you'll need to know like, oh, that's bipolar 1 versus bipolar 2. So just make sure you know the difference between the two. So bipolar 1 client is experiencing or has experienced a full syndrome of manic or mixed symptoms, may also have experienced episodes of depression. And then bipolar 2, it's characterized by bouts of major depression with episodic occurrences of hypomania. So they never go into full manic episodes. And she won't give you something like this. She'll tell you like hypomania or something like that. She'll make it pretty clear as long as you know which is which. And so for this patient, because of that, now we're thinking, okay, actually it's probably bipolar. And so we need to like rethink our medication and do something different. And then another thing is, there's something else I thought of that I was like, oh yeah, you guys should. Oh, did she talk about, I can't remember if it's this test or the last test. Did she talk about how you need to look at if patients have physical problems, and if they do, then we're not diagnosing them with personality disorders? Like if they have cancer or something like that?
Was
I
it
know.
the sickle cell one?
Yeah,
Yeah, that was in the question. That
the
was
question bank.
You
mhm.
mean hyper or hyperthyroidism?
Yes. Did she talk about that at all? Like if they have a physical ailment, then we shouldn't really be diagnosing them with a personality disorder?
I think
We
she
need to
did that
rethink it.
last exam.
Why?
Okay.
Like you have to take into account that their personality is changed by their condition, like by their diagnosis.
Yeah, so a personality disorder, it needs to be like completely based off personality and not, it's not drug induced. So if they have a history of drug abuse we're not diagnosing them with a personality disorder because it could be something related to the drugs. And then if a patient has like sickle cell anemia or hypothyroidism, or they get cancer and suddenly they're depressed, we're not we're not diagnosing them with like bipolar or anything like that, because there's a physical issue that may be causing the emotional symptoms, where personality disorders is strictly like, this is the personality and there's nothing physical causing it. It's not drugs, it's not alcohol withdrawal, it's not like a physical disease process that they have. So if a patient is diagnosed with a personality disorder and then come to find out like, oh, they actually have hypothyroidism, or they actually have, you know, something like that, or they have a history of drug abuse, then we're going to rethink just like the diagnosis and go from there. So I can't remember if that's this test or not, or the next test, but sometimes she throws in random stuff like that. So just keep that in mind, that if they have a physical like ailment, then we're going to say, we're going to fix that first and then kind of see what's going on. A patient diagnosed with bipolar disorder has a goal to gain 2 pounds in a week. Which nursing intervention accomplishes this goal? Okay, good. So with these patients, the best thing is to provide high calorie finger foods, because they're so manic that they're not able to even just sit and think. And so a lot of times they'll be showing signs of like anorexia, like not on purpose, they're not trying to lose weight, but they'll just start dropping pounds because they're not eating. And so like one of the nursing diagnoses will be like altered nutrition or something like that, because or impaired nutrition, because they're not focused on eating. They're just too busy in their heads with all these things they have to do, and they have all this energy that eating is not a priority for them. So they'll start losing weight. And so if they're a patient that has that issue, then we're going to try to get them to gain weight by giving them high calorie finger foods. So like, hey, here's some waffle sticks with syrup, because they can eat that while they're walking around. So anything that they can just eat really quick and that has high calories, we're going to get them to do that. Which nursing approach should be used to maintain a therapeutic relationship with a patient diagnosed with borderline personality disorder? Oh, I didn't finish the first one, sorry, to avoid something. Job. Okay. So we're always being firm, consistent, clear, concise rules. And the reason it's not this one is because they won't act well with like this authoritative leadership of just like dictatorship, right? So we're not like, even though like, yes, like we're the ones in charge, we're setting rules, we're not acting like a dictator, like you can't because you can't. Like we're being empathetic, like this is why, explaining the rules behind it. And also we're not trying to get them to conform to societal norms, because they probably never will. And so it's more like to get them to work within society without having to be completely confined by societal norms. And so I just think of it again, I go back to like the teacher or the mom, like the best teachers you had, right, in school were the ones that had good classroom control, but they weren't like absolute a-holes, right? Like they weren't like, everybody shuts up and nobody talks in this class and like you are super silent while we do like whatever, right? Like they were firm, but they also were kind, if that makes sense. Same with parenting, like same idea. I don't know if that helps anybody, but sometimes being able to relate it to something like in a different sense. can be helpful. Which patient is a nurse most likely to admit to an inpatient facility for self-destructive behaviors? Okay, good. So histrionic, remember, they're not really like self-destruct. I mean, there's some self-destructive a little bit, but they're mostly just exaggerating everything that happens. And so, like it says, they're attention seeking, outgoing and sociable, seductive, manipulative. But it doesn't actually say that they are self-destructive. So they are dependent on people. They have this dramatic extroverted behavior, but they're not really doing self-destruction. Antisocial are for sure not self-destructive. They think that they are so above like everybody else that like they destroy other people's lives because they're so like exploitive, and they just have no remorse for people, but they're not self-destructive because they just think they're the best things ever. Same with like narcissistic is similar. And then obsessive compulsive, it's not really self-destructive. I mean, unless you're thinking like in general, mental health disorders are all kind of like destructive, but they're not displaying these self-destructive where they're harming themselves. Patients diagnosed with borderline personality disorder, they will go to extreme lengths to do self-destructive behaviors in order to get the attention they need. So they have these intense chaotic relationships. So they'll enter into relationships that are very toxic, and they will they're very emotionally unstable, and they will do all these things just to try to like kind of like get attention, and it's like a cry for help kind of. And like I said, like there was a question I saw on a quiz bank that said something like if you have a patient with a borderline personality disorder, what like and their favorite nurse is leaving for the day, like what is the thing they would most likely tell the nurse? And so they like would they like give them a big hug and say like you can't leave, I love you too much, you're my favorite nurse? Or would they say like you can't leave because if you do I'll just cry in my room all night? Or would they stab themselves with a pen and say like you're leaving and so I had to like stab myself, so now you have to stay? Like they're gonna go to the most extreme impulsive behavior. So when you're thinking borderline personality, just whatever is extreme, that's probably the right answer. So they're gonna like seriously injure themselves in order to get the attention they're seeking. Okay, so select all that apply. Which of the following rationales by a nurse explains to parents why it is difficult to diagnose a child with bipolar disorder? Okay. Wait, there's another one that was right, I think. Oh, maybe it's just those two. No, okay, it's just those two. Okay, so with children, the reason that it's hard to diagnose is because a lot of times it mimics ADHD symptoms. So they are very excitable and they kind of, act manic. They can't sit still. And so that really mimics ADHD in children, especially little boys. And so sometimes, and like like we've talked about, there's no test for it. So it's just so hard. Psych is really, I think, one of the harder disciplines because it's a lot of guesswork because you're just guessing based off of signs and symptoms. There's no diagnostic tests for a lot of this stuff. And so it's hard to diagnose children because those symptoms are so similar with ADHD. And then also they're naturally energetic, spontaneous, and active. And so, like I said, these people that have bipolar as adults, they're very childlike in some ways because they just talk a mile a minute and they don't know how to, like if they read a book, they're going to tell you, they don't know how to give you a synopsis, right? Like, and then in this chapter, she said this, and then in this chapter, and it's like talking to a first grader. Like they can't give a synopsis. They can't sit still. They're going to talk a mile a minute. They're going to have this flight of ideas where like they're talking about chocolate. And then the next minute they're talking about their aunt's birthday party. And then they're talking about this bird that they saw at their aunt's birthday party that was dead. And they don't know if they believe in heaven or not, like from one to the other, like so fast. And so sometimes that's just kids, and kids are kind of crazy. And so that's why it's hard to diagnose children. Genetic predisposition is actually a really reliable diagnostic determinant. So if your family has a history of bipolar disorder, then it's not that there's a good chance, but then it's easier to diagnose because if you have symptoms, you're like, well, if you have a family history, there is this genetic predisposition. This just isn't true. Children can experience psychosis. There's no like age of when a person can or can't experience psychosis. I don't know if this is true or not. But that's not a reason why it's difficult to diagnose with bipolar disorder. I don't know if neurotransmitter levels vary. I would guess it's the same. And then we can diagnose before the age of 18. So I'm glad no one picked that one. So there was a question on ours that was like similar to that, where we have to know like why you can't diagnose children or why it's hard. You can, but it's hard. An alteration in mood that is expressed by feelings of elation, inflated self-esteem, grandiosity, and hyperactivity. So what is that called? Okay, good. So that's mania. So you know how on every test there's like one or two that you have to fill in the blank? This was, I think, one of them. So this is going to be mania. So make sure you know, like at the very beginning of her slides, she always has like a definition, or usually has a definition. So I would know the definition for mania. I would know the definition for I think there was something in substance abuse that I was like, oh yeah, I know that. Oh, the difference between physical dependence and psychological dependence. Definitely know that. And then there was something else that I was like, oh yeah, I know that one. I would definitely know that, like, not exact definition. Oh, affect. So, and mood. So mood is defined as a pervasive and sustained emotion that may have a major influence on a person's perception of the world. Affect is described as the emotional reaction associated with an experience. So I would just know, like, I feel like there were 2 on this test, maybe 3. There's always like 2 to 3, right? Where you have to fill in the blank. And I don't remember for sure. I feel like this for sure was one of them, was mania, but I don't remember the other one. And so I would just know this is in the bipolar disorder. It's like the first 2 slides. She has a couple of like bolded words with a definition. So just know it enough like that you can recognize it, right? Because you don't have to sit there and type in the definition, but enough that you see it and you're like, oh, that's mania. Oh, that's mood. That's affect, whatever.
During BED, she said that there was going to be a fill in the blank on mania and hypomania.
Okay. Okay, good. So then, yeah, know those. Which of the following instructions regarding lithium therapy should be included in discharge teaching? This is select all that apply. You will definitely need to know this. Well, we had to know it. Okay, so they need to consume a lot of fluids. Okay, so I'm glad that nobody picked these two. So we're not restricting fluids and we're not restricting sodium intake. We have to make sure they have adequate sodium intake because lithium acts like a salt, and can take the place of of salts. And so we have to make sure that lithium is not taking that place, that we have regular salts. So that way the salts do what they're supposed to do. Because even though lithium acts like a salt, it doesn't act like it in the body. It just acts enough like a salt to take the place of like those receptors. And so, but it's not going to do the same thing on the body. So we need enough sodium so that sodium can sit on those little like receptors and then do their job. We're avoiding excessive use of caffeinated beverages. So just, I feel like with most of these disease processes, we're seeing that. So try to limit your caffeine. And then lots of fluids. So I feel like the only time we're saying restrict fluids is if the patient has heart failure or like increased cranial like pressure. Other than that, I feel like you're probably safe going with like consume more fluids. How often are we having serum lithium levels checked?
Isn't
You guys
it
remember?
like 3 months?
It's 1 to 2 months.
Okay.
So I don't think she'll ask you like exactly how much, but I would know. I mean, you're gonna have to know it because she could have a question that says like every 3 months or every, I don't know, 6 months or whatever. So just know it's 1 to 2 months that you're having it checked. And then also, let me go to lithium because I think that's the only one she really. Did she say anything in B80 about like any other drugs besides lithium that you really need to know?
Valproic acid.
Okay. That's what I had on mine too, but I don't know if I feel like she's one of those teachers that never changes her test, so you're probably safe. So with the
Well, she told
valproic
us she
acid,
just updated it, so I don't know.
oh, really? Oh,
She's like, I
okay,
made a few
well,
updates. I was like, great.
I don't know if I believe that. Maybe she did. Okay, so with the valproic acid, it's like you have to know like the limits or something, right? Like I'm trying to find that one. What did she say to know about valproic acid? Just know it?
Therapeutic range of 50 to 150, and
Okay.
just that it's like a mood stabilizer, like an off-label use for this anti-epileptic. That would be a mood stabilizer.
Okay. She might have added that because I have on mine. Oh, I do have no therapeutic levels. I just didn't write it in there. So I also have verapamil is used as a mood stabilizer. I don't know if you guys need to know that. But for sure, no lithium because she will definitely ask about sodium. With all of these drugs, I would just assume that if you see like an answer of like, oh, they can take it whenever they want, or they can stop whenever they want, but that's false. Okay. So with most of these like drugs, they need to take it regularly in order to get to the therapeutic level. They probably should take it at like the same time, and they need to taper off. Okay. And so I would just assume that those are the correct answers because there's so very few meds that they can just stop immediately or that they don't have to take it, regularly, that you're probably always right if you just choose that.
She also was saying that you can use it with olanzapine to the olanzapine and the lithium can be used together because the olanzapine is a mood stabilizer that'll work quicker because the lithium takes X amount of weeks to work or something like that. I think it was 4 to 6 weeks.
Okay. Yeah. So if she said no, that I don't remember that specifically. But if she's updating things, and I would probably know that just lithium takes a while to kick in. And so it's not going to be like, because there can always be a question, and this is with any like antipsychotic, antidepressant, anti-anxiety, they take 4 to 6 weeks to kick in. And so if you have any question that the patient's like, that asks something like, which statement by the patient requires further education or something like that. If it's something like, I should be feeling better in a week, that's false. Okay. It's probably always going to be 4 to 6 weeks. And this isn't on depression, but just keep in mind that with patients with depression, after about a week, they're going to start feeling more energy. And so then we're upping our one-to-one watching them because now they have the energy to commit suicide because like they have energy, but now they haven't, but it hasn't fully kicked in where they're actually feeling better. And then the therapeutic range for lithium is 0.6 to 1.2. So I would know that. And then they have like toxicity symptoms, which I don't think she'll have you list them, but I would know enough that you could recognize it. So if it's like, and I have a question in here that's similar, but if it's like a patient comes in with these symptoms, like as a psych nurse, you would recognize that like, oh, these are symptoms of lithium toxicity. Like if they tell you like, I'm on lithium, then you're gonna be like, oh, that's lithium toxicity. So, I mean, if a patient just came in and didn't tell you they're on lithium, these could be symptoms of a ton of other things. But knowing they're on lithium, you could be like, oh, that's lithium toxicity. Oh, here's Johnny. That's funny. Who did that one? That's hilarious. That's very old. I'm like impressed that somebody knows that. A patient has been taking lithium, for a year. He presents to the ED with a temp of 101, blurred vision, and tinnitus. What are we thinking?
We get this one wrong.
I know. Like, we literally just talked about this. Yay. Okay, so their lithium toxicity. So I would just know, I don't think tyramine has anything to do. I think that was like a medication from last time. Unless I'm wrong, someone like shout out if I'm wrong. But I would just recognize the signs of lithium toxicity. Don't memorize them because I would be shocked if she has you list them. I don't think she's gonna do that. She might have a question similar to this and you're like, oh, lithium toxicity. But she's gonna tell you they're taking lithium. So like, then just guess lithium toxicity. And OCD, remember, this is OCD personality disorder. Patient learns that the nursing staff will now alternate weekend shifts. Which response is expected? Hey, good job. Okay, so the first one, I don't think that's specific to any disease process. That's probably just a regular person that's like a friend empathizing with you. Like, I just called sick, so you don't have to work weekends. It's not this one because this is going to be someone with like some sort of paranoia issue. Like there's a hidden agenda. Like why are you doing this? They're always questioning something. This is probably going to be more somebody that is antisocial or narcissistic. So they feel like they're in a position where they can make demands. Like I demand that I have a regular schedule. I am so important that you have to work your schedule around me. And this would be OCD, and personality couldn't fit. So that's why I couldn't put that. But remember, it's personality disorder. And they just aren't able to handle it. So they are so inflexible that if there's a nursing schedule change where it's like, well, every other weekend, they're just going to kind of freak out because just the idea of the schedule changing, so they don't know which nurse is coming in when, is going to really affect them. What should be the priority nursing diagnosis for a patient experiencing alcohol withdrawal? Good. Okay, so it's always going to be risk for injury. That's their first thing, like when they're first experiencing it. Once they've kind of gotten through that withdrawal, like after like a week or two, Then we're looking at these other things, okay? Maybe not the hallucinations so much, but for sure these two. But at first, it's risk for injury because there are so many issues that are going on with them. Okay, last question. A lonely, depressed divorcee has been self-medicating with cocaine for the past year. This patient is experiencing Okay, so psychological addiction. So know the difference between the two. So let me look it up exactly what she has. But physical is basically like it's somebody that like they don't want to take it. It's not like, oh, I feel like I have to. I really want that high. It's they have to, or they're gonna be like sick. And so they have to take it, or they're gonna be like physically ill. So physical dependence is the need for increasing amounts to produce the desired effects, and it's a syndrome of withdrawal upon cessation. Psychological dependence is an overwhelming desire to repeat the use of a particular drug to produce pleasure or to avoid discomfort. So physical is more just because of the physical effects. And so I know when San Gill was our teacher, she talked about like in psych, not psych, sorry, farm. She talked about how her husband was given some sort of drug for like when he had, I don't know if it was opioid or whatever. And he developed a physical dependence to it where like he didn't want to take it, but when he stopped taking it, his body reacted with withdrawals. And so he actually had to take like withdrawal medication because his body got addicted to it. So his mind wasn't, but his body was. And then psychological is where they want to take it because they want that high, or they want to avoid the bad things that, like, you know, this person who is divorced and lonely and depressed, they want to avoid those bad feelings. And so they have this psychological dependence to avoid that. Good job. Adam, is that you, AH?
Yeah.
I feel like you always come in. Joey, you got 4th. I'm surprised you didn't get 2nd.
I stumbled at the beginning, couldn't catch up.
Okay, so there's just, I'm just gonna stop share real quick. There's a couple, let me just, hold on one second. Okay. All right, so there's just a couple of things I want to go over under the substance ones. I only got those 2 in there before I ran out of time. Let's see. So I think you only have to know alcohol and opioids, right? So I would just know personality factors can increase a tendency towards addictive behavior. So low self-esteem, frequent depression, inability to relax, inability to communicate effectively. So just anything that like people have like certain personality traits, or if they have a family history of it, or if they have like a sociocultural factors. So there's different things that can cause a person to have these addictions. I don't think you're going to have to know all the phases like pre-alcoholic, early alcoholic, crucial, chronic. I wouldn't worry about that. Did she talk about Wernicke's encephalopathy? Like that you have to know that?
I don't remember that.
Okay. It's in her slides, but I don't think that that is something that you have to know.
She did talk about it in class, but it wasn't on our exam review.
Okay, okay, good. If you go by the exam review, you should be pretty good. I feel like, do you guys feel like her exam reviews are very similar to her tests?
Pretty accurate, yeah.
Okay, okay. So I think if you go off of that, you'll be very, very well set off. So I would just I feel like going through this, there's not a lot of stuff that I'm like, oh, definitely know this. I would know that they're gonna have denial about it, obviously. They're gonna have ineffective coping. Especially with alcohol, they're gonna have imbalanced nutrition just because they're so focused on drinking that they're not gonna have time to eat. And so a lot of times, unless they have ascites where they have like that big belly because of cirrhosis, they could be really thin. Also fluid volume deficit because they're only drinking alcohol and that dehydrates you. Risk for infection because their immune system is so bad. I'm looking for the part where it talks about, okay, people won't die from opioid withdrawal, but they will get really sick. So we're giving them a safe and supportive environment, a place where they can have these symptoms of withdrawal. I'm just looking for, I thought that she had a list of like things that they can experience with withdrawal, but now I'm not seeing that. So maybe she doesn't. Oh, okay, so definitely know this. So it is on slide, I have it on slide like 35. It talks about nurses using narcotics. I would know the clues for recognizing substance abuse in nurses. She will most likely have a question about that. So they're gonna have, they're gonna rarely miss work if they're getting their source at work. So if their source is stealing the opioids from patients, they're gonna be picking up extra shifts. They're not hardly ever gonna miss work. If their source is outside of work, if they have a drug dealer or it's alcohol, then they're going to be absent a lot because they're getting high outside of work. So I would definitely know those two things because I feel like that was for sure a question. You're going to see an increase in wasting of drugs, higher record of signing out drugs than for other nurses may be present. Poor concentration, difficulty meeting deadlines, inappropriate responses, poor memory or recall, problems with relationships. So just go over, I think it's slide 35, 36. I would know that. Oh, and then it goes through 37 also. So irritability, tendency to isolate. Just go over those. Okay, and then she will probably ask a question about the state board response. And I think one of the questions was like, one of the possible answers was like, the BRN will revoke something like it will like the absolute thing they will do is revoke your license, no questions asked. And that's not true. So they can deny, they can suspend, they can revoke a license, but they may not. So sometimes they allow nurses to avoid disciplinary action by agreeing to seek treatment. And so I would know that they're not automatically going to revoke it because that will, that was a question on ours where she said like, what, like kind of like, what is the BRN going to do? Or the state board. And then what, like another question, I can't remember if it was the same question or a different one. It might've been two questions on this because so many nurses, like 15%, I think she said, become addicted to drugs or alcohol or something. So you have to have evidence of a regular attendance program at a nurse support groups, random negative drug screens, and employment or volunteer activities. So you need to be showing that you're doing these things, and there's no guarantee that they'll keep your license, but this will help. So that's on slide 38 and 39, I think. Yeah. And then I would know anti-abuse is a deterrent to drinking alcohol. So what it will do is that you'll take it, and then when you drink alcohol, it literally makes you physically ill. And so I would know what that's used for and what it does. So it's not gonna, it doesn't cure alcoholism and it doesn't treat side effects or withdrawals, but it makes you sick when you drink alcohol. So that's what anti-abuse is, or disulfiram. I think anti-abuse is the generic. And then I would go over the last slide on the substance abuse where she talks about what they're giving with alcohol withdrawal. So benzodiazepines for substitution therapy, because we do need to give them something to substitute just for like physical safety. Anticonvulsants if they're having seizures, multivitamins for lost nutrition, and then thiamine as treatment or prevention of Wernicke's encephalopathy. I don't think she'll ask you that one, but she might ask about like the benzos or just like substitution therapy. So that's what I would know for that one. And then I think the others, I think as long as you follow her guide, you'll be fine. And then I know with all your free time, I would start now, probably every day, just do 10 questions of dynamic quizzing on Psych, on ATI. Because on the ATI exam, ours had a lot of drug questions. And so it was a lot of like, a patient's taking this drug, what side effects would you expect? Or a patient's taking this drug, what other drug can they not take with it? And I think that our professor is an excellent psych professor, but I don't think she is great at preparing you for psych medications. She kind of glances over them, and then there's not a lot on the test. And at least on our ATI, and it changes every time, but there was a lot of psych drugs. And then I asked a 4th semester student and they said it was the same for them. So I do think the ATI focuses on psych or on medications. So I mean, if you just do 10 questions a day, that'll take you like 20 minutes. So I would just do that, just start doing that now so that you can at least get your 2. So, in all your spare time, right? And then I think that's it. And then I will send, if anyone needs to start studying now for their finals, I do have the study guide for the med-surg final that I can send out. It's Martin's study guide, so it's possible San Gil's will be different. But at least for San Gil's class, you could kind of use the information. And I would just, when you're referencing it, I would double check, because I remember I filled it all out and then I sent it to my friends, and I think there was like one thing they're like, oh, this is actually wrong. And I don't remember if I changed it. So just double check it when you're looking at it, that my information is correct, because I'm human and make mistakes and it's not always perfect. So, but it should be a good like help for you to kind of at least like get started on your studying if you want it. So, any questions?
And they've got solid